Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. The topic of discussion for our program tonight is the quality issue in medicine, part 2. During the first part, we had the opportunity to interview 3 physicians in our community, and I'd like to invite them back again to continue with the discussion, what we left off at the end of the first segment. Ladies and gentlemen, we are talking about the family as a consideration in quality medical care. Maybe you can talk a little bit more about it because we were rushing out of the program.
Well, I think what we were relating to, Dr. Weed had mentioned the utilization of critical paths or clinical paths whereby a team of care providers, especially in the hospital setting, would get together and discuss variations in the way processes were implemented and then try to come to some agreement on standardization of the best practice. And what that would do would be to give a path to the caregivers to see what should happen on a particular day, say for a surgical patient. And the comment that I made is that in addition to that critical path for the caregivers, several institutions are making critical paths for the patient and the family, so that a surgical patient, for instance, would come in and get a piece of paper which would describe what will happen in the pre-admission period, what testing has to be done and why, what would happen when they come to the hospital, what would happen to them during surgery and how long they could expect to be in the operating room. A lot of places even let the patient and family visit the intensive care unit, so it allays some of the fears of the unknown. And then an idea of what 3 or 4 things have to happen post-operatively before they'll be ready to go home. And often they give an estimated date of discharge. And I think setting that expectation for the patient and the family does a lot to help the hospital personnel in achieving adequate utilization of the hospital services, because I think in the past, of course, it never happened at any of our hospitals.
Of course not.
But you know, if someone couldn't get off of work to take grandmom home Friday morning, you know, there was no question that she would stay till Saturday morning until it was more convenient for the family. And certainly there wasn't a realization that that extra day is costing somebody a lot of money. And that those type of social supports had to be evaluated and determined before grandmom ever came in the hospital.
Actually, what you're saying is that we're beginning, very fortunately, to look at the medical care or the practice of medicine as really multidimensional. And it's not like, you know, 1 and 1 is 2. In other words, I think one of the big misunderstanding or misconception about quality medical care is maybe exemplified by the quick fix ideas. In other words, like a cataract surgery, for example. Take that as an example. A patient doesn't see, go to see the ophthalmologist, half an hour later he comes out and he sees. And everything seems to quantify or qualify quality medical care that way. And that is just one of the many things that I think that are very rare in the whole sphere of medical practice. There's so many issues that you have to consider. That's why in one another show that I produced, I was mentioning that it really is important for people to know how an internist operates. I mean, you know, he has things about so many factors involving the care of a patient. And it's not like a quick operation and comes out and quantify or qualify it that way. And I think that is good. I think that is a very healthy kind of development. But maybe
I'd like to see if I can change the direction a little bit of what we were talking about. Hospital care, which is what we've been talking about almost entirely, and quality issues within a hospital setting. Hospital care is becoming a much smaller part of medical care in this country as more and more healthcare is provided on an outpatient basis. Outpatient surgery is now 70% of all surgery. People don't go in the hospital anymore other than in basically an ICU, intensive care unit type of thing, or for other long-term or more acute processes. So we have to develop ways of providing these same methodologies of quality care, of developing clinical paths, of measuring how we do things in the outpatient setting, and that's a very different story than in the hospital, where we have an opportunity to follow people very closely. And it's done in really, each physician is working by himself and caring for patients. But as we move into an era when costs are important and where we have got to reduce the costs, looking not only at costs but in ways of doing things better in the outpatient setting, taking care of a diabetic patient, taking care of an arthritic person, taking care of a child who is simply following through the path of immunizations, well baby checks, and so forth. We're beginning to standardize some of those things and hopefully going to improve the outcome of our outpatient care as well. And that's the majority of the care in this country now.
I think that's very appropriate, and it's fascinating because it's going to be even much harder, because the variation are going to be even much more than in the hospitals. Because in the hospital you have more controlled environment. You take care of very sick patients there, so there's a lot of scrutiny, a lot of supervision. But out there in the outpatient, each person practices a different way. Like typical comment of a lot of patients saying that if I go to see 10 different doctors, I have 10 different management and treatments. And how to go about standardizing that is going to be a big task and yet very significant job, isn't it?
Well, I think what you have to do first is measure the variation that's out there. I think even if you talk to physicians, and some of these studies have been done, again, it relates to a hospital situation, but asking obstetricians what their C-section rates are and how they respond to guidelines. This study was done in Canada, where they had the physicians give their idea of what they did. They received the education, and then they changed their behavior and again give us self-reporting. And they found when they actually did the measurements, the doctors who thought they had improved, in fact, some of their values had gotten worse. All the problems that we have with determining databases in the hospital, I think, as Dick was pointing out, is compounded about how you do that in the outpatients. And one of the things that came to me as you were speaking, Dick, it almost sort of ensures that the standalone physician is a dying entity, because to develop databases, and some physicians do this in their practice, again, we talk about databases at the hospital, but multi-specialty groups or groups of family practitioners are going to have the database to say, not only do we say this is what we do, but here's the data to prove it. And I think that is starting to happen mainly because the health payers are sending back data to the physicians, and you will get your report card from this health plan or the other. And I think what the doctors have to do is be sure that data is correct. Because we know some are making judgments about whether or not doctors will maintain their membership in plans and be able to take care of patients based on those data reports, and I know some of them are not accurate. So I think it's forcing the physicians to develop and know their own data.
Some don't take into account the enormous variation in patients and don't measure those things accurately, and it's been not just distressing but ruinous to some physicians who have been good physicians and have been basically cut out of their practice. On the other hand, the development of methodologies to measure those things is really important if we're going to improve the kind of care. I keep picking on Bob, the studies that showed that in one community of men over 65, they have I've forgotten what, 10% have had a transurethral resection in a community with just as good doctors, same demographics, but 50 miles away, that 60% have had, and my figures may be wrong, but why we do things differently, I think we're doing it exactly right, are sure we are, not because we're trying to do something too many times or otherwise, but because we think that's best for our patients. The answer is we don't know what's best for our patients.
I don't know if I agree with you. You know, I have observed, unfortunately, in my career, is that a lot of times physicians do things not because he thinks best for the patient. For example, taking the outrageous utilization of antibiotics. I mean, to me, I was practicing pediatrics for a long time, okay? And I mean, it's the jungle out there. I mean, the utilization of antibiotics is outrageous and has nothing to do with patient's welfare or anything like that, you know. You take 10 kids to come in with a cold, and you give them Tylenol, you give them a water, you give them some thyme, or give them penicillin shot, or, you know, C-Claw, whatever you name it, you know, the outcome is the same. So that the doctors who do all those things claim that he has done the right thing for the patient. Is that true? Of course not. I mean, he has no comparison to go by. And very often, unfortunately, it's dictated by economics. If he has to do that to make the patients happy, spending very little time, he would do it. You see?
Well, you know, hopefully part of the lesson physicians will learn from clinical or critical pathways that are being used in hospitals is that if we can limit variation, we can be more cost effective and our outcomes will be better, and that's true. Now, you know, how well that's going to play out and how well that total quality management concept that's worked in industry will work in healthcare, I think we're still trying to solve that. I think, as Mary said, though, the health plans are starting to scrutinize very carefully what's going on in offices. Physicians are tired of being micromanaged, and some health plans, some insurance plans are very wisely saying, okay, we've watched your practice for X number of months or years. We will no longer subject you to this bombardment of calls about everything that you do because you've proven that you can be cost effective. So there's going to be some reward in that regard, just like the disincentive when a physician is told you can no longer be part of our plan because you aren't cost effective. So I think that's how we're going to see things shaping up in the outpatient.
I believe the main, the key to improvement would be to compromise the interest of the three players here, the physicians, the consumers or the patients, and the third-party payers. And sometimes their interests or their goals are very conflicting. And it has a lot to do with how to establish an avenue of communication among those three payers, which we don't have so far. I mean,
You know, let me give you an example of how this can work. There's probably no good reason to do a prostate biopsy on every male over 75 that has a prostate nodule. A physician needs to think, will this be something that's going to result in an immediate treatment program for that individual? Prostate cancer has become an extremely popular thing to talk about. People, stars and television personalities speak out about their prostate cancer. And so we have, in some instances, 80, 85-year-old men that are having prostate biopsies to the tune of about $1,100. And I've asked some of my colleagues, why are you doing that? Well, you know, the family wants it. And in all fairness to clinicians, the time it takes to convince a family or a patient that they don't need that, we sometimes just don't have. So you're a bad guy if you don't do it. And even if you've taken the time, I've had patients that have gone elsewhere and they've gotten their biopsy.
but maybe if they have to pay for it, there would be a,
Well, that's what
there would be a
we
difference.
talked about earlier.
Because if you talk about accountability, they want it because they don't have to pay for it.
Sure,
So they don't
that's
have to worry about
part
what
of
is
the
that
problem.
for. They believe that's the right thing to do, but if they have to pay for it, there will be a different issue, isn't it?
I think the other thing that I just thought of when you were talking about that, reflecting on what Dick said about the multidisciplinary group coming to address the problem, I think what you said about the three different interests, the provider, the physician, the payer, and the patient, I think we need to see more of those three representatives coming together to really talk about how decisions are to be made, what's best from the perspective of the patient. And I think we do need to do better education to let the patient and the family know what are the options for therapy, biopsy or no biopsy. If they elect to go with the no biopsy, what is the likelihood of their longevity without further symptomatology? And I think one of the advances that's really impressed me is the video cassette educational devices, especially in your field, where they have two physicians, one that decided to go ahead and have, in this case, prostate surgery, and one who decided not to. And it was very interesting to see in the two physicians where it was a very personal issue for them to go through the analysis that they did, each one of them coming to a different conclusion for themselves. And I think that kind of information that's now available to physicians in their practice to give to patients and family is, to me, a very hopeful sign of getting education out there and getting all the parties together to do what's best.
I want to go back to the situation of antibiotic use again, because I think that's probably the easiest thing to understand where the rationale goes wrong. I mentioned earlier to you that I coined the term the Marie Antoinette syndrome, which says that, if they don't like amoxicillin, give them Ciclo, which is is really sad, because what happened is that a lot of people think the state of the art is the newest thing, because they think it's more expensive, it's newer, therefore it's better. And it's not true at all. It just makes things very confusing, and sometimes it makes things worse, because if you utilize more and more antibiotics, you create new strains all the time. But the physicians don't spend the time doing that, so that the public is so ingrained into thinking that what is called a state of the art, whether it's a slogan from the pharmaceutical company or whoever thinks it's state of the art, never taking into consideration the cost issue. I think the cost issue is going to be the driving force into changing our thinking, because if we're accountable for what we do things very differently.
Yeah, I think that's very true, especially with the antibiotics, because I think the issue is which one will give us the best outcome in the most cost-efficient manner.
Sure.
And as you pointed out, sometimes that is not always the latest and the best and broadest spectrum costly antibiotic, and we have seen that in some of the studies we've done.
However, with the advent of managed care, formularies are being developed which say these are the drugs you can use, and you can't go to the new fourth generation drugs until certain things have taken place. In other words, there are screens put in to say when you can go past that. You can get around that if you have a particular problem by special methods, but for the average case, you meaning the practicing physician, is being driven to using more, not only cost-effective drugs, but less worrisome from the standpoint of developing antibiotic resistance and so forth. It's not a perfect answer, and it's being driven by dollars rather than necessarily always scientific good sense. But it's still happening, and organizations of physicians, as well as others, are trying to develop methods in which the physicians in a given group, and as more physicians are in groups all the time, and their survival is based on their ability to not only provide good care but cost-effective care, they are really looking at antibiotics, and they're looking at procedures and x-rays and CT scans and what have you. So
in any industry, they have what they call quality-price ratio. It's easier to, I guess, to compare two cars or two apples or two cantaloupes. But if you want to have the same kind of quality but better price, then compete with the other. But the situation in medicine is that there is no accountability, so nobody knows who pays for what. I think that is very, very damaging concept that I think that when we're driven home in terms of, finding out the accountability of each clinical pathway, we have a much clearer view as to which is better.
But that's what we have to work with. And as long as the system is operating that way, we have to try to figure out ways to overcome that obstacle, and it is a tremendous obstacle when people feel that they're entitled to the best and they don't have to worry about the financial repercussions. What about, let me just ask you, what about the instance of using antibiotics when really no antibiotics are indicated? Because if you don't give them something, they feel as though they've been cheated.
Well, you have to have incentives. You see, in other words, the patient or the doctor have to be rewarded for not doing. And again, it comes back to the accountability. You see, oftentimes, I think that we can do it different ways, But the issue is psychosocial. It's not, and psychological. It has nothing to do with scientific concept whatsoever. Because, if, again, I think it has to do with the credibility of the physician. If the patient trusts and respects the physician is doing the right thing, then whatever antibiotic he prescribes is going to be okay. But the problem is this, the problem I see is enormous, because we have created a monster medical industry where so many people depend on certain things to be done to make a living. Let's put it bluntly that way. 300,000 angioplasties annually are unnecessary. You have so many people dependent on it to make a living. They need to have their biases. They need to defend their stance. There's no question about it. But the data shows clearly that they're not necessary. So they have to justify that, just like tobacco. If you eliminate tobacco, there are going to be a lot of people who are going to be out of a job. So it's a very sensitive kind of issue. But I don't see any way to go around improving it than to lay it on the table and openly discuss it.
Yeah, well, I think one of the other issues I think that you have to consider, and let's just use that for an example. Someone comes to your office and has symptoms, they're miserable, and they want an antibiotic. I think part of the patient's reaction is, I'm here anyway, I'm spending good time and money, and I didn't come here for you to tell me it's a virus and to go home and go to bed. I think one of the ways around that, which a lot of doctor groups are doing, is having these advice nurses available to screen and talk to patients so that they don't have to have the expense of coming in for a visit. And I think a lot of times they're able to review the symptomatology and say, well, I don't think that requires a visit to the doctor. It sounds at this point that it's a virus. Why don't you go back to bed and then check with us tomorrow? And I think both the patient and the physician is sort of off the hook on that one just because they haven't made contact, whereas the physician's the backup. If tomorrow the temperature's 104 and they're having chest pain, they need to come in. So I think that's
very true,
one of the modalities
because
that
actually
helps.
there's a study recently, I think came out of Vermont or something. They're talking about using the phone as substitute for doctor's visits. And they have data that shows it's very effective. If you can convince the patient that the outcome is the same, staying home, doing whatever, and you have to document that, they will believe you. But you see, we automatically for a long time, what you do is that come in to see me, because that creates what I call codependency. You're up my back and I up yours, and that kind of thing. And that is very wrong, because in the long run, both parties lose, because you create a misinformation, because you choose to do it the easy way, and because it's become a habit, And I practiced pediatrics for a very long time, and I knew for a fact that a lot of problems could be solved on a phone. But because of the economic nature of the situation, the patient comes to the doctor's office, which is a waste of his time and resources and energy. But that's the way it has been done, and it has to change.
See her hand.
See her hand.
I think Kaiser has successfully used the phone-in system, the telephone nurse, to help patients
Yeah.
calling in, screening their calls
Right.
so that they don't have to come into the clinics.
Yeah.
I know that in my office, I try to have available a variety of literature,
Yeah.
either patient education materials about specific diseases,
Yeah.
and even more importantly, in the past few years with healthcare crisis, educational materials about
Right.
how patients might approach their healthcare differently
Yeah.
and their expectations.
Yeah, right. It seems like the trend for the future would be spending more time and resources in communicating and educating instead of treating or doing things.
Yes.
I think we are going to use in the future many more what are now called advanced practice nurses, nurse practitioners, and also physician assistants to assist physicians in providing care. Many of the things we do not require medical school education and a residency for 4 or 5 years afterwards,
Yeah.
but can be treated very well by people who are trained and knowledgeable and under the direction of physicians, and I think we'll
Yeah.
see much more of that in the future.
Yeah.
It's being used effectively now in organizations like Planned Parenthood and also in some doctors' offices.
Yeah.
And it's a way to provide quality care at a lower cost.
And hopefully that's not going to be a threat to the physicians. There's a source of less influence or less income, I guess.
I think one of the good things about managed care is that we've gone full cycle back to preventive health.
Yeah.
And the difference is, 20 years ago, everyone knew it was effective, but nobody was paying for it.
Right.
And now, at least with the managed care dollar, you're supposed to be reimbursed for
Unfortunately,
doing
there's
it.
So anyway,
very used in it.
I'm afraid we're running out of time, so I'm sorry I have to cut you off, but we're closing down on the second segment of the issue of quality in medicine. I'm Dr. Hung Vu. Our show is America's Healthcare Crisis. Thank you for watching. Till next time, good night.
Someone, have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone